Hello everybody. Today this is Dr. BK for you with another topic. So in this topic today I am going to discuss about the anatomy of the arm. So in this lecture I will be discussing about the muscles, vessels and the nerves of the arm. So our learning objectives for today will be the compartments of the arm. So what are the compartments present in the arm and what are the muscles present in these compartments, followed by the blood vessels. So only one major artery is present in the arm, that is the brachial artery, followed by the nerves of the arm. So what are all the nerves which are passing through the arm and the branches given by them in this specific region, that is the arm, and followed by that finally we conclude our session with the applied anatomy. Okay, now before going directly into the arm is also called as the brachium. Okay, and the bone of the arm is the humerus. Okay, our arm is attached to the trunk by the means of the pectoral girdle. So to understand the muscle attachments of the arm, it is better to recap quickly the osteology of the arm, which is the humerus bone. So the humerus bone is a long bone which you see here. It is a very classical example of a long bone. So it ossifies through endochondral ossification. Okay, it has a shaft and two ends, and the upper end is rounded and spherical, which is actually called as the head of the arm. Okay, apart from the head you have a constriction which is actually the anatomical neck of the humerus. Then the upper end you also have in the upper end the greater tubercle and the lesser tubercle of the humerus. Followed by that what you see is a constriction, that is the surgical neck of the humerus. Then you see the shaft of the humerus, which is somewhat round or cylindrical in the upper part, but in the lower part what happens, it becomes triangular. Okay, then if you trace, it has got three borders and three surfaces, mainly the medial and the lateral border. If you trace laterally, it forms the supracondylar ridge. This sharp margin is actually called as a medial and lateral supracondylar ridge, which again ends in two rounded prominence, which is the medial and lateral epicondyle. Okay, so that is the medial and lateral epicondyle. In the lower part you also come across a process projecting anteriorly, which is called as the trochlea. This is actually called as the trochlea of the humerus. It has two downward growth, which is the medial flange of the trochlea and the lateral flange of the trochlea. So I will speak about the importance of this medial and lateral flange of the trochlea in the elbow joint lecture. Okay, so that is the trochlea. Followed by that what you see here is the laterally is the capitulum. Okay, that is actually the capitulum. Above the trochlea what you see, this is the coronoid fossa. Above the capitulum what you see is the radial fossa. Now posteriorly when you come across, the tubercles are very well seen. Okay, this is actually the posterior view and this is the anterior view. So here only you see the trochlea and this is the coronoid fossa, and above that what you see is the radial fossa. Okay, and the lesser tubercle and the greater tubercle. Posteriorly what you see, a very good view of the greater tubercle you are able to see here. Then you see a very deep fossa posteriorly, which is actually called as the olecranon fossa. Okay, this is actually the olecranon fossa. So again I repeat, this is the posterior view of the humerus and this is actually the anterior view of the humerus. So this should be your left humerus anterior view, and this is the posterior view of the left humerus. So trochlea, above that coronoid fossa, capitulum, above that what you have is the radial fossa. Posteriorly you have again a deep depression which is actually called as the olecranon fossa. And on the posterior aspect of the shaft again you see a spiral groove or the radial groove. The other name for the radial groove is the spiral groove. So that is an enlarged version where you are able to see the anterior part, intertubercular sulcus. By the two lips of the intertubercular sulcus you are able to see. It is also called as the bicipital groove. And this is the greater tubercle, this is the lesser tubercle. Greater tubercle, only half of it you are able to see here in the anterior aspect. Posterior aspect you will see the remaining. This is the surgical neck and this is the anatomical neck and this is the surgical neck of humerus. Coming to the deep fascia of the arm, the deep fascia of the arm is actually called as the brachial fascia. Okay, so it is actually called as the brachial fascia, and it continues downwards as the fascia of the forearm, which is actually called as the antebrachial fascia. This is the deep fascia which covers the muscles. Now the deep fascia, what happens is it is going to send some septa and gets attached to the borders of the humerus. So thereby you see two septa. One is the medial intermuscular septum and other one is the lateral intermuscular septum. So these intermuscular septum only divides the muscle into groups. So what you see anteriorly is the anterior group and what you see posteriorly is the posterior group. Okay. The intermuscular septa not only forms the muscular compartments but also it provides attachment for the muscles. So laterally some muscles arise, medially also it gives attachment to one muscle. Then it is also pierced by the nerves and vessels, because nerves and vessels, if you have to pass from one compartment to another compartment, definitely they will be piercing. Now for example, lateral muscular septum, intermuscular septum will be pierced by the radial nerve, medial intermuscular septum will be pierced by the ulnar nerve. Apart from that, arteries also pierce the intermuscular septum and go to the posterior compartment. Okay, so the main function of the intermuscular septum, they are modification of deep fascia and they actually divide the muscles into compartments. If you trace these intermuscular septa, below they are attached along the borders of the supracondylar ridge up to the epicondyles, that is the medial and lateral epicondyle. Okay, so now we will directly move on to the compartments of the arm. Mainly you have the anterior or the flexor compartment. The muscles are three muscles. One is the coracobrachialis, other one is the biceps brachii, and other muscle is the brachialis muscle. The artery of this compartment is the brachial artery, and the nerve you see here is the ulnar nerve and the median nerve, musculocutaneous nerve, and also the partly you come across radial nerve in the lower part of the arm. So all the four nerves you will be able to see in the flexor compartment: musculocutaneous, median nerve, ulnar nerve, and little bit of the radial nerve. Posterior or extensor compartment, you have only one muscle, that is the triceps brachii muscle, and the artery is the profunda brachii artery, which is a branch of the brachial artery. So profunda brachii artery is one of the largest branch of brachial artery. Then the nerve on the posterior compartment is mainly by the radial nerve. So now we are going to see the muscles of the anterior compartment. The first muscle what you see here is a very small muscle, the coracobrachialis. So it arises from the coracoid process and it is going to get inserted into the arm, middle of the shaft of the arm, middle of the shaft, medial border. It represents the adductor compartment, but in humans or in the upper limb of humans, the adductor compartment is very much reduced because there is not much function for the adductor compartment. That is why it is only represented by a very small muscle, that is the coracobrachialis muscle. Then, as I told you, morphologically it represents the adductor compartment. this coracobrachialis muscle will be pierced by a nerve which is actually called as the musculocutaneous nerve. So you want to identify musculocutaneous nerve, then it should pass between the coracobrachialis. Or if you want to identify coracobrachialis, it should be pierced by the musculocutaneous nerve. So you can use either or thing to identify these two structures, but sometimes coracobrachialis muscle will not be pierced by the musculocutaneous nerve. Then apart from that, certain points of interest like at the level of insertion of coracobrachialis, some changes takes place. One is the shaft of the humerus changes from the cylindrical to the triangular shape. That is one thing. The nutrient artery of the humerus enters into the nutrient foramen at the level of insertion of coracobrachialis. The median nerve is going to cross the brachial artery from lateral side to medial side at the level of the coracobrachialis. The medial and lateral intermuscular septum gets well defined at the level of coracobrachialis. The basilic vein will pierce the deep fascia, and what happens, it is going to continue as the axillary vein at the level of insertion of coracobrachialis. Okay, so these are all certain things which is appreciated if you are able to remember this, but not necessarily you should memorize all these things. So nerve supply, as I told you, it is a musculocutaneous nerve, very weak flexor of the shoulder joint. It's not a very powerful flexor because, as I told you, morphologically it represents the adductor compartment, which is very much reduced and not much of a functional importance in case of humans. So the ligament of Struthers. So what is the ligament of Struthers? Is sometimes there might be a third head of the coracobrachialis which might arise from the supratrochlear spur of the humerus and gets inserted into the medial condyle. Third head. Okay. Now that third head will be, what happens, it gets degenerated and it represents as a ligament which is called as the ligament of Struthers. If at all this ligament presents, then naturally what happens is it might compress the brachial artery or the median nerve, which might lead to some vascular or neuro symptoms. Okay, so that is one thing, and you might wonder why actually the musculocutaneous nerve pierces the coracobrachialis muscle. It actually does not pierce, because I told you originally it has two heads and in the lower forms three heads. When they fuse in the course of evolution, what happens is the nerve gets trapped between this, and finally it appears in humans as if this nerve is piercing the muscle. The next muscle, very important muscle which we are going to see here, is the biceps brachii muscle. Fusiform in shape. So fusiform muscle, you are able to see here with two heads. One is actually the long head of biceps, another one is the short head of biceps. So the short head arises from the coracobrachialis and long head arises from the supraglenoid tubercle. But when you look in the cadaver, what happens is the long head will appear short because the intracapsular part is hidden from your view and it actually appears this is a long head. Both the heads, they fuse, are able to understand, and gets inserted into the tuberosity of the ulna. They get inserted into the tuberosity of the ulna. This is an intracapsular structure, the long head, tendon of long head, which is passing through the bicipital groove along with the synovial sheath covering the tendon. So apart from the insertion into the tuberosity of the radius, here you are able to see one more extension of the tendon only, flattening of the tendon, which is the aponeurosis, bicipital aponeurosis, as a subcutaneous insertion on the posterior border of the upper part of the ulna. Okay, so attached to the subcutaneous part on the medial border of the forearm. The nerve supply to the biceps brachii muscle is the musculocutaneous nerve. So the three muscles of the arm is going to be supplied by the musculocutaneous nerve. Okay, so coming to the action of the biceps, it is a very powerful supinator of arm. So supination of the forearm is the anti-gravity action. So supination, so where you turn the palm of your hand facing upwards. So it is a powerful supinator. So mainly when you want to screw something with your hand, so you do alternating pronation and supination. Of these two, supination is a very powerful anti-gravity movement which your biceps muscle aids, and it is to some extent flexor of elbow only in a supinated elbow. Okay, so in a supinated elbow, what happens is it acts as a flexor, that is called a spurt muscle. So I have discussed about what is spurt muscle, what is shunt muscle in the general anatomy classes in the muscular system. So powerful supinator and also a flexor, especially in a supinated elbow. The next muscle actually called as the brachialis. Now why the brachialis is also called as the muscle of the arm? Because it originates in the arm, whereas the other two muscles actually originates from the scapula. It is present at a deeper plane deep to the biceps. So now only if you remove the biceps, you are able to see the brachialis muscle. This is the coracobrachialis pierced by the musculocutaneous nerve. So deep to the biceps, what you see here is the brachialis muscle. From the lower half of the shaft of the humerus, and I told you from the medial intermuscular septum. So intermuscular septum also gives origin to muscles, not only they form facial compartments. So from the medial intermuscular septum and lower part of the shaft of the humerus, the biceps brachii arises and gets inserted into the ulna, that is the tuberosity of ulna, and also to the process anteriorly which is called as the coronoid process. To the coronoid process as well as to the tuberosity of ulna, it gets inserted. Its action is, this is actually the principal flexor of forearm. So flexion of forearm, mainly strong flexor of forearm is your brachialis muscle. Okay, nerve supply is mainly by musculocutaneous nerve, but it also derives, a small part of the muscle is actually deriving its nerve supply from the radial nerve. But some books describe that radial nerve only carries not motor fibers but proprioceptive fibers. So which means muscle sensation, the radial nerve is involved. So because of its dual nerve supply, the brachialis muscle is also called or regarded as the hybrid muscle. Okay, it is called as the hybrid. So whenever you come across the term hybrid muscle, means it has got two different nerve supply. So that is about the muscles of the anterior or flexor compartment. The muscle of the posterior compartment is the triceps brachii muscle. It is called as triceps brachii because it is made up of three heads. Okay, the three heads are the long head which is arising from the infraglenoid tubercle, the lateral head which is arising above the spiral groove or radial groove, and then the medial head which is actually arising from the shaft of the humerus below the radial groove. This is also lateral head from the shaft of the humerus above the radial groove. Okay, so long head, lateral head and the medial head. Three heads, you are able to see the triceps muscle. So this is actually the long head of the triceps muscle, and this is your lateral head of the triceps muscle. All the three heads, they fuse and they are going to get inserted into the olecranon process of ulna. So it is the olecranon process of ulna, and it is the main action of the triceps muscle is, it is an extensor of forearm or extension of elbow joint. Okay, so it is the only chief extensor of the forearm, or you can tell extensor of the elbow joint. The nerve supply is by the radial nerve. So the nerve supply is actually by the radial nerve. It is an extensor of elbow joint, origin by three heads, that is why it is actually called as the triceps muscle, and gets inserted into the olecranon process of ulna. Okay, so we finished with the muscles of the arm, three muscles in the anterior compartment: coracobrachialis, biceps brachii and brachialis. One muscle in the posterior compartment or the extensor compartment, that is the triceps muscle. Now we are actually going to discuss about the arteries. The main chief artery which is present in the arm is the brachial artery. The brachial artery is a continuation of the axillary artery, and then it divides into two terminal branches, that is the radial and ulnar artery at the level of neck of radius. Okay, so the brachial artery divides into radial and ulnar artery at the level of neck of radius. Okay, the extent of the brachial artery is going to be from the lower border of the teres major, where the axillary artery ends, lower border of teres major, to the neck of radius, where actually it is going to divide into two terminal branches. So it is almost superficial in its course, deep to the biceps brachii, and almost present on the medial aspect. Okay, medial aspect and also related to the median nerve. At the lower part, what happens of the arm, the median nerve is going to cross the brachial artery anteriorly, and in the lower part of the arm, it is the cubital fossa, it will be seen medial to the artery. So that means the median nerve crosses the artery anteriorly from lateral side to the medial side. So that is why it is actually mentioned as it is crossed by the median nerve. Okay, so in the cubital fossa, it is going to lie between the tendon of biceps laterally and the median nerve medially. In between these two, actually it is an intermediate structure, the brachial artery. So now coming to the branches of the brachial artery. So here you are able to see the brachial artery branches. It is going to give muscular branches mainly, which is going to supply the muscles of the arm, sole blood supply. So that is why it is going to give muscular branches. Nutrient artery, blood supply to the long bone through nutrient artery, which is going to enter to the nutrient foramen of the humerus. Then the largest branch of brachial artery is the profunda brachii artery. So profunda means it is actually deeper, profound. That is why it is called as the profunda brachii artery. Then superior ulnar collateral artery, and it is also going to give inferior ulnar collateral artery. So superior ulnar collateral artery and inferior ulnar collateral artery, it is again going to anastomose around the anterior ulnar recurrent and posterior ulnar recurrent arteries. So they are all anastomoses around the elbow joint. Okay, so branches are muscular branches, nutrient artery to humerus, profunda brachii artery, superior ulnar collateral artery, which is going to pierce the intramuscular, medial intramuscular septum, and it is going to go behind. Inferior ulnar collateral artery 5 cm above the elbow, again it is going to pierce medial intramuscular septum and going to go behind and takes part in the anastomosis around the elbow joint. Okay, so the terminal branches are the radial artery laterally and the ulnar artery medially. So two terminal branches and other 4 branches, these are the branches of the brachial artery. Next, the largest branch of the brachial artery is the profunda brachii artery, which is the largest branch, as I told you, seen in the radial groove along with the radial nerve. So behind you are able to see the radial groove, the profunda brachii artery is lodged along with the radial nerve. It divides into an ascending branch and a descending branch. Okay, so ascending and a descending branch. These descending branches is going to take part in the anastomosis around the elbow joint. Superior ulnar, inferior ulnar, it is mainly taking part also anastomosis around the elbow, but the medial aspect, medial condyle and ulna. Along the radial aspect, it is going to be the branches from the profunda brachii, that is the radial collateral and artery. You are able to see here the radial collateral artery mainly, and that is going to anastomose with the branches from the radial artery. Okay, branches from the radial artery, radial recurrent artery. Okay, then you also have the middle collateral artery, which is given by the profunda brachii artery. Okay, middle collateral artery is one of the branches which is given by the profunda brachii artery. So coming to the applied anatomy of the brachial artery, arterial pulsations can very easily be felt. Okay, that is one thing. Then this is the most preferred artery for recording the blood pressure. So with the sphygmomanometer, if you want to record the blood pressure of the patient, then naturally what happens is it is the brachial artery which is present, because as you know it is present superficially throughout its course. So that is the applied anatomy with respect to the brachial artery. One more thing which I will discuss at the end of this session about the brachial artery applied anatomy. Now coming to the nerves of the arm, here you are able to see first nerve is the musculocutaneous nerve, also called as the nerve of the arm, because this supplies majority of the muscles of the arm. The front of the arm, all the three muscles are mainly supplied by the musculocutaneous nerve. Arises from the lateral cord of brachial plexus, root values C5, C6 and C7. It is present lateral to the brachial artery. So lateral cord, naturally it should be present lateral to the brachial artery. Pierces the coracobrachialis muscle. Okay, so enters the arm by piercing the coracobrachialis. So kindly just note down this error here. It is written musculocutaneous nerve. Actually it is enters the arm by piercing the coracobrachialis muscle. So that is the musculocutaneous nerve, and it is present between the superficial and deep muscles, that is between the biceps and the brachialis muscle. So runs between the biceps and the brachialis muscle. And what happens is in the lower part of the arm, it is going to continue as the lateral cutaneous nerve of forearm. So that is why it is partly muscular, partly cutaneous. It is called as the musculocutaneous nerve. So it supplies coracobrachialis, it supplies biceps, then it supplies brachialis, and it also gives articular branches sometimes to the shoulder joint, but main branches to the shoulder joint is by the axillary nerve and the lateral pectoral nerve. Okay, so next nerve which you see in the front of the arm is the median nerve. So this nerve is actually the median nerve, joining by root of median and lateral root of median. In front of the third part of axillary artery, this union takes place. The root value of median nerve is C5, C6, C7, C8 and T1, because it is the union of the medial root as well as the lateral root. And the upper part of the arm, it is actually present lateral to the artery, but at the level of insertion of this coracobrachialis muscle, it crosses the artery anteriorly and then comes to lie medially, the lower part of the arm and the cubital fossa. So first present lateral, then what happens? Crosses the artery and it is present medial. So what are all the branches given by the median nerve? So arm muscles, it does not give any branches. Here in the cubital fossa, it gives branches to one muscle, that is the pronator teres muscle. Then articular branches to the elbow joint and vascular branches to the brachial artery, because it is intimately related to the brachial artery. Okay, so pronator teres, branch to pronator teres, articular branches to elbow joint and vascular branches to the brachial artery. The next nerve you come across is the ulnar nerve. You are able to see the ulnar nerve, which is from the medial cord of the brachial plexus. First it is present posteriorly to the first part of axillary artery, then in the third part of axillary artery it is present medially. Actually it is seen in the posterior compartment behind the medial intermuscular septum. Okay, so pierces the medial intermuscular septum and enters the posterior compartment after some time in the arm. Okay, here you are able to see the ulnar nerve pierces the muscular septum, and what happens is it enters the posterior compartment, which is shown in the dotted line. So while it is passing, it will pass behind a sulcus posterior to the medial epicondyle, that is actually called as the nervi sulci ulnaris. So there actually the nerve is superficial and can be rolled against the bone, that is the medial epicondyle. So that is why accidentally when you come across any hard object or you hit your medial epicondyle, the ulnar nerve might give a tingling sensation, and it is considered as a funny sensation, and that is why the humerus bone itself is named as humerus. Okay, there is a reason for naming the humerus as humerus. Okay, So that is about the ulnar nerve. Now coming to the next nerve, which is the radial nerve. So if you look at the radial nerve in the arm, so from the lower triangular space, then it is seen in the radial groove. Okay, spiral groove or radial groove along with the profunda brachii vessels. So it winds around the posterior surface of the shaft of the humerus and mainly supplies branches to the lateral head and the medial head. Okay, lateral head and medial head. So pierces the lateral intermuscular septum. Here see, you are able to see it is piercing the lateral intermuscular septum in the lowermost part of the arm, and it enters the lateral part of the arm more laterally, and it is going to supply some muscles there, mainly your brachioradialis, small branch to brachialis, and extensor carpi radialis. So these are the branches it will be given in the arm, medial and lateral head of triceps, and one more small muscle which is the anconeus muscle. Articular branches to the elbow joint. Okay. Now if the radial nerve is damaged in the radial groove, you know, all the extensors below will get paralyzed and you get a condition which is called as the wrist drop, but extension of forearm is not affected. Why? Because the long head of the triceps and the lateral head of the triceps receives its nerve supply from the radial nerve or branches from the radial nerve before the radial nerve enters the spiral groove. So this is actually called as the triceps escape. So triceps alone escapes, whereas all the other muscles supplied by the radial nerve gets paralyzed. Okay, so in the radial groove it mainly supplies the lateral head as well as the medial head. An additional branch will lead to the lateral head because before that it has already supplied the long head and lateral head of triceps. So that is mainly about the radial nerve. So coming to the applied anatomy, what is Workman's ischemic contracture? I already told you that I will be discussing one more applied anatomy with respect to the brachial artery. See, this is normal. Now slowly what happens, because of the contraction, you see edema of the forearm, which means the brachial artery has been compressed. Okay, some pressure has been put. This mainly occurs in the supracondylar fractures of the humerus in the elbow region. So when there is a supracondylar fracture, the lower bone fragment might actually compress this brachial nerve, thereby cutting off the blood supply or compromising the blood supply to the forearm. The forearm will become edematous and contraction of the arm takes place with the flexion of the wrist. Okay, that is why it is called as Workman's ischemic contraction. Okay, then actually I told you about triceps escape, injury to the radial nerve in the spiral groove, long head and the lateral head is not affected. Then ulnar nerve might get again compressed in the cubital tunnel. So here you are able to see the cubital tunnel, which is again formed by fascials to this one extending from the two heads of flexor carpi ulnaris to the ulnar bone. The nerve, the ulnar nerve might get compressed here. Then medial border of the arm, there might be lack of sensations, and it might also lead to claw hand because of the innervation to the intrinsic muscles or short muscles of the hand will be interfered. Okay, so we finished with the arm, the muscles of the arm. Then we have discussed about the blood vessels, mainly the brachial artery. Then we have discussed about the nerves, the course of the nerves in the arm: musculocutaneous nerve, medial nerve, radial nerve, and ulnar nerve. Ulnar nerve does not give any significant branches in the arm. Only the musculocutaneous nerve gives, and same way median nerve also only in the cubital fossa it is going to give or supply the pronate arteries. Apart from that, it might give some vascular branches to the brachial artery. Radial nerve gives branches in the arm to the triceps muscle, and then it also gives a small part, it supplies the brachialis, then brachioradialis and extensor carpi radialis. So with respect to the cubital fossa, we are going to understand the situation, boundaries, contents, applied anatomy of the cubital fossa. So here you are able to see surface representation of the cubital fossa. It is a depression or a hollow in front of the elbow which is roughly triangular in shape. Okay, there is a space between the muscles which is roughly triangular in shape. So the boundaries, it has an apex, it has a base, then it has a medial border, then it has a lateral border. Apex, base, medial border and lateral border. Then it is covered by roof, and the depth forms the floor of the cubital fossa. Okay. The boundaries of the cubital fossa, medially it is actually formed by the pronator teres muscle, exactly the medial border of the pronator teres. Okay, so that is the medial border of the pronator teres. Laterally it is formed by the lateral border of brachioradialis. So medially it is formed by the lateral border of pronator teres, and laterally it is formed by the medial border of brachioradialis. Okay, the brachioradialis muscle, even though it is an extensor muscle, it is seen in the flexor compartment for the functional reasons. Okay, don't get carried away by this muscle which is seen in the flexor compartment and try to identify it as a flexor muscle. Apex is formed by the meeting point of these two muscles, or meeting point of the medial boundary and the lateral boundary. Base is actually an imaginary line which is drawn across the two condyles of the humerus or epicondyles. It is an imaginary line. There is no such structure as base. Apex, as I told you, is the meeting point of the medial and the lateral borders, the pronator teres and the brachioradialis. Now coming to the roof, so this is actually the roof of the cubital fossa, mainly formed by skin, superficial fascia, deep fascia. In the deep fascia you have one structure, that is the bicipital aponeurosis. Okay. So deep to the skin, in the superficial fascia, mainly these are the structures you come across. Veins, mainly very important structure, the median cubital vein. Runs diagonally in the roof of the cubital fossa, connects the cephalic vein with the basilic vein, and it also has a tributary receiving it, which is the antebrachial vein or the intermediate. It is also called the median vein, antebrachial vein. Then you see the cutaneous nerves, the medial and lateral cutaneous nerve of the forearm. So median cubital vein, medial and lateral cutaneous nerve of the forearm are the structures which you see in the superficial fascia or the roof of the cubital fossa. Okay. Then deep to this, the deep fascia, what you see here is the bicipital aponeurosis, an extension of the tendon, flattening of the tendon of the biceps muscle getting inserted subcutaneously into the medial border of the forearm. So median cubital vein, important applied anatomy is, it is present on top of the bicipital aponeurosis. The preferred vein for venipuncture or to give intravenous injections or for IV fluids. One thing, it is superficially present. So that is why this is the vein of choice for venipuncture. Second thing, it is present on top of bicipital aponeurosis. So during withdrawal of blood or venipuncture, what happens is none other of the deeper structures are easily damaged. The third thing is, this is connected to a deep vein by a perforator vein. So perforators are veins which connect the superficial vein and the deep vein. So because it is actually anchored deeply with the help of a perforator vein, this vein does not slip from the needle very easily. So a little bit of experience you have, then what happens is you can very easily withdraw blood or give IV fluids through this median cubital vein. Okay. Next, coming to the floor. So here you are able to see the floor is mainly formed by two muscles. The insertion of the brachialis muscle into the coronary process and the supinator muscle. So these two muscles form the floor of the cubital fossa. So this part, only the cubital fossa imaginary line forms the base. Floor is mainly formed this area, the tendon of brachialis inserting into the ulna, and this area is by the supinator muscle which wraps around the lateral surface of the shaft of the radius. So these two muscles form the floor of the cubital fossa. Contents: from medial to lateral, you have the median nerve, brachial artery dividing into the radial and the ulnar artery, tendon of biceps, and more laterally the radial nerve. Okay, median nerve, brachial artery and its terminal branches, tendon of biceps, and the radial nerve. So from medial to lateral they form. Some of the books they don't include the radial nerve, but radial nerve should be included. It is the most lateral structure in the cubital fossa, and here only it is going to give branches to the brachioradialis, extensor carpi radialis longus, and the extensor carpi radialis brevis. Okay, so that is the base, and here you are able to see median nerve, most medial structure, followed by the brachial artery dividing into two terminal branches at the level of neck of radius, tendon of biceps getting inserted into the radial tuberosity, and more laterally you are able to see the radial nerve which is going to pass into the supinator muscle. So before passing, actually it divides into a deep branch and a superficial branch, and it is also supplying brachioradialis and extensor carpi radialis longus and brevis muscle. So median nerve, we have seen about the contents one by one we are going to see. So supplies the pronator teres above the elbow. It is going to give branches to the pronator teres, and it is going to pass between the two heads of the pronator teres. Median nerve leaves the cubital fossa and enters the forearm by passing between the two heads of pronator teres. So between the humeral and ulnar head, gives branches to the muscles, especially from the medial side. Okay. The next structure is the brachial artery, intermediate structure which is present between the tendon of biceps and the median nerve. Divides into radial and ulnar artery, terminal branches at the level of or opposite the neck of radius. The branches given by this radial and ulnar artery are the radial recurrent, anterior and posterior ulnar recurrent, and common interosseous artery. So all these branches we are again going to deal this in the forearm. So tendon of biceps, you are able to see this is the tendon of biceps getting inserted into the posterior part of the radial tuberosity, and aponeurosis is an extension from the tendon, attaches to the subcutaneous posterior border of the ulna. And finally the radial nerve appears in the gap between the brachialis and brachioradialis medially, and between the extensor carpi radialis. Medially brachialis, laterally brachioradialis, and extensor carpi radialis. That is the radial nerve for you. As I told you, divides into superficial and deep branch. Deep branch is going to enter into the supinator muscle. Okay. So cubital tunnel syndrome, mainly you see here, it is because of the ulnar nerve getting trapped. As I told you, the flexor carpi ulnaris, from a facial extension from this to the humerus or the ulnar bones or the olecranon process of ulna. So it might get trapped because of this, the cubital tunnel, and naturally what happens is the medial border of the forearm, loss of sensations, then medial part of the flexors and intrinsic muscles of the hand might get involved, forming claw hand. So thank you very much for listening to the lecture on the arm. So we will meet again with some other lecture shortly.